Welcome back, everybody, to the latter half of today's Frugal Innovation Forum 2022. So those of you who were here yesterday probably remember the 3 brilliant impact talks that we've had right after lunch, just like today. Over there, we heard from Oranjoy Da from BRAC Microfinance. We heard from Sudan Gurung, and we heard from Richa. And 3 of them spoke of 3 very interesting ways to make impact through the lenses of practitioners, of innovators, and inventors. Today, we have 2 more sessions for you, and we're going to start off with Ahmed Mushfiq Mobarak. Dr. Mobarak is a professor of economics at Yale University with concurrent appointments in the School of Management and the Department of Economics. He's the founder and faculty director of the Yale Research Initiative on Innovation and Scale, also referred to, abbreviated to as YRISE. He has several ongoing projects in Bangladesh, Nepal, Sierra Leone, and conducts field experiments exploring different ways of introducing developing countries to adopt technologies and trying to inculcate behaviors that lead to better welfare and better life. So without further ado, I'd like to invite Dr. Mushfiq Mobarak, who you'll see on the screen in a few minutes.
Highlight the fact that even after you set up big development distribution mechanisms, right, you actually need to solve very practical challenges around last mile delivery to get vaccines in the arms of people. So I'll use the exact same map that Dr. Saad Omer showed you earlier today, right? So this is what I'm showing you: share of population fully vaccinated, and as you saw in his presentation, the share of first doses look very, very similar, right? There is emerging vaccine inequity, and it's really concentrated in Africa, right? And that's one of the reasons that we will, our research site will be Sierra Leone in West Africa. So now zooming in from the continent and the world into what's happening in Sierra Leone. About 23% of the population has received a first dose until now, and only 15% of the population has has been fully vaccinated with 2 doses, okay, or with the Johnson & Johnson. And a lot of these vaccines arrived late. So vaccination rates really have been lagging, and they continue to lag. So now when you ask the question, why are vaccination rates lagging in Sierra Leone, in Africa, more broadly, and low and middle income countries even more broadly, where even though South Asia is now caught up, right, it did lag compared to what was happening in the Western world. Okay? So there are 3 categories of answers that come up. So the first category of answers we heard a lot about today in the panel with Dr. Michael Kramer and Dr. Saad Omer, right? Which is about what I'll characterize as international supply chain failures, right? Which has to do with the incentives that various countries have in production and then distribution and selling of vaccines, and who's first in line in getting it. Okay, so we talked a lot about this. I won't delve any more into it. So there's the international supply chain issues. And then the second set of issues, when African scholars, policymakers have been complaining about the fact that there have been these international supply chain failures that have effectively withheld vaccines from Africans, right? The counter argument that we already heard, again, in the earlier panel, is that, actually, if we were to send vaccines to Africa, they often don't get used, they get wasted because there's so much hesitancy around vaccines. Okay? Like the CEO of Pfizer, for example, is on record saying things like that. Now, so with Saad, with Nicolo, with many other researchers, whose names you won't be able, there's so many you won't be able to read fast enough. So we looked at this systematically, right? And the way we did it was we asked the same vaccine hesitancy acceptance questions across 15 samples, so 10 plus countries, low and middle income countries in Sub-Saharan Africa, in South Asia, in Latin America, right? And then also asked the exact same question in the United States and in Russia as benchmarks. Okay? And what we learned from all that data, just asking the question about vaccine acceptance in the same way across different countries, what we learned is that in every single low and middle income country we study, vaccine acceptance is actually higher than it is in the United States, and it's much higher than it is in Russia, right? So just on the face of it, just from the descriptive data, it just doesn't seem like this is an important part of the story. Okay? This just doesn't seem right. Okay? So in spite of that, we do have to confront the fact that, yes, doses do get wasted sometimes. So where does it come from? Why is it, people who are running pharmaceutical companies, people who are running Western countries, they're not dumb, they're smart people. So why are they claiming that there's hesitancy? Okay? And the reason is that there are problems that might end up looking like hesitancy, but it really isn't. Okay? And that problem is in last mile delivery and access. Okay? So people aren't vaccine hesitant, but they're also not like vaccine eager or vaccine enthusiasts, right? So we collected data first in Sierra Leone before running any trial, right? And our data, like pretty much nationally representative data, shows that on average, it takes a person about 3 hours each way to go to the nearest vaccination center. And it costs about $6.50, right? So when you're asking people in rural areas to spend an entire day, maybe overnight, right? Spend about 2 weeks of salary in a location where they're living on $1.50 a day, right? That's what you need to do to go get vaccinated. Under those conditions, where it would cost 2 weeks of our salary, you and I would not be getting vaccinated. Okay? And so when you have this kind of tremendous acute access problems, right? It looks like hesitancy. People aren't showing up. People aren't showing up because the vaccines aren't anywhere close to them. It's not at all convenient. Okay, and so this is just an early attempt by our team to get vaccines out to rural areas. Like, stuff happens, access challenges are real. These are the kinds of practical problems that we need to address. Okay, so now the other thing that if you look in Sierra Leone, when I'm characterizing it as an infrastructure problem and access problem, there is a lot of variation across districts, right? So the red marks are where we ended up doing our study, where we ended up running trials. But you see that in some rural areas, like a lot of the vaccination rates are pretty high, say in Freetown and in large markets and large towns, right? But they tend to be much lower in much more rural areas. And so when you do see vaccinations, we do have a quarter of the population now having received one dose, 15%. So where is it? How is it happening? So this is something that Dr. Kangbai will talk about later in more depth. But a lot of it's happening to what they call surge campaigns, right? And the surge campaigns are designed around health facilities. So both town health centers, but also what's called peripheral health units. So now the surge campaigns are specific days of the month where many, many doses are available and many people show up at the health facilities and they get their vaccines. So why am I calling it a surge campaign? You see that on a particular day, there are massive increases in vaccination. Okay. Now these surge campaigns are designed around the system of health facilities. This is a map. The dots are the union of like big health centers as well as these peripheral health units, PHUs, right? So they're distributed across Sierra Leone, but they're not providing, getting to some of these health facilities from some of the areas of the maps that's just white, colorless, right? It's difficult, and that's where that 2 weeks of wages comes from. Okay, so what we ended up doing was, we started looking at, okay, in the peripheral health units, right? What is their catchment area? So typically they have the mandate to cover 5-mile radius around the catchment area. So this is just a picture I took in one of the peripheral health units in Port Loko district called Katonga. And so what we ended up doing was we took all these peripheral health units and we drew 5-mile radii around them, right? And then we tried to select to try and understand how to solve the last mile delivery problem. We purposefully selected the hardest to reach areas, right? So the blue dots, which typically fall outside of even the very peripheral health facilities, okay? Now, we couldn't always get it right. So you'll see sometimes the blue dots fall within the 5-mile radius. Why is that? It's because we were using a 2016 list of facilities that was available to us, but by 2022, there were many more facilities that were built. So some are going to be very, very remote, and some are going to be now a little bit less remote, right? But still, I mean, these are all, the peripheral health units have the P for a reason. They're already peripheral, right? And we're talking about areas that are not even covered by those types of units. Okay, so that led to, that was our sampling frame. And then we randomly selected a set of facilities to work with. And the blue versus red was randomly assigned to either treatment or control. Okay, so now let me explain to you what the treatments were. Okay, so the control areas, we went and collected data on vaccination rates. We did not do any intervention. And in the treatment areas, we basically enhanced access, right? We took vaccines to those communities. And I'll show you a series of pictures of what exactly enhanced access means, what set of actions you have to take, okay? And then within the treatment, we divided up into two groups where in addition to providing that last mile delivery, we either complemented that with like some door-to-door outreach, like knocking on doors and trying to get people to our temporary vaccination centers. And the reason we did that is that sometimes, there might be a young man who's scared of needles, but wouldn't want to actually admit that in front of the community, right? So it might make sense for us to have an individual conversation where we can work through his fear of needles, right? But then we also noticed that sometimes, if somebody has a WhatsApp, WhatsApp is really dangerous. If somebody has a WhatsApp account, right? Sometimes they get strange information about vaccines and it quickly spreads among his or her friends and neighbors, typically his. And so we also tried a different treatment where we were trying to identify those small groups and trying to counter that kind of misinformation, right? Okay, so I'm going to concentrate first on showing you what the last mile delivery of vaccines means. Okay, and I'm going to just do this in the form of photos. Okay, so step one is that you need to go in to the community, first meet with the community leaders and socialize the concept that we're bringing vaccines. This is why it's important. And we need to get the community together and involved in quickly getting vaccinated, right? So just going in and calling during the day, calling a meeting of the local leaders. And the leaders might be in many different domains, right? Both men and women of the community. Okay? So then we asked them, we try to get them or get their blessings, right? And we asked them to then convene the entire community that same evening. We're also trying to do it very cost effectively and efficiently. So everything I'm going to describe to you gets done in around 48 to 60 hours, okay? So we asked them in that same evening to try and convene all the community members to try and have a meeting where we can explain the importance of vaccines, okay? So this is a picture taken that same evening. And why is it in the evening? So after people come back from the farms, in this particular community, that was a sensible time to have this meeting, right? So that everybody is there, or as many people as possible is present, and there's no excuse that I'm working out in the field. Okay? And this is a case where, issues might come up because there might be subsets of the community, individual members who are really hesitant about vaccines or think that they are problematic or evil or dangerous, right? And we in some communities, we're going to face a lot of stiff resistance at this stage, okay? But we try to get everybody to understand why we're doing this, why it's important. And so when we say we, these are Ministry of Health, well, they're called volunteers, but they're really like people who work, they're not regular salaried staff, but they're people who work against per diems, okay? And as well as any community health workers that might be in the nearby area. So they're the ones who are leading these conversations. Okay? Yeah, and in this picture that I took, there's a white guy there with the Patagonia shirt, but that white guy who happens to be sitting here is typically not there. This is just a piloting. So this is an unrepresented picture with an Italian guy solving Sierra Leone. Okay, joking. All right. So now that we've basically, we explain why we're doing this and there's going to be a vaccine clinic. Now, the next step is we have to get the vaccines to that community, right? And as I said, these are very, very remote areas. So that picture right in the middle, right, is just a picture from the vehicle as to after you get here, which is already an hour away from the nearest health clinic, you still have a long ways to go, okay? And in lots of places, we, it's only accessible not by vehicles, by things like motorbikes. So our trick for a lot of places was essentially to put vaccines in the back of motorbikes, that you see that green cooler. And then the picture to the left is nurses in the backs of motorbikes. So you also have to get the professionals who can administer the vaccines out to the communities, both the people as well as the needles themselves, right? And the pictures in the bottom are the peripheral health unit where the vaccine is typically stored, right? That's going to be about often to a couple of hours away. Okay? And I want to also point out, because we're going to be talking about the cost of doing this, that the types of locations where we are trying to cover sometimes are extremely inaccessible, right? So these are pictures shared on WhatsApp with us, with our teams, and they're doing hard work, right? Any of the Ministry of Health staff members who are going out, sometimes they're facing really stiff, just geographic resistance, even before talking to any individual, right? So some places are really hard to get to. Okay. All right. So what's the next step? We set up the vaccine clinic, right? So this is what the clinic looks like, right? So there are nurses, the vaccine's available, and we did those earlier steps in order to mobilize the community to come and try and show up for this vaccine clinic. Right? But notice that it's not just about having a nurse present to just administer a jab. We also have to have, we're connected with the Ministry of Health system. So we have the vaccination cards. So there are other Ministry of Health officials who are also recording vaccinations and giving people cards. And that's also an important aspect of the entire intervention, right? And by the way, the reason why we chose to locate in these very remote areas, our project in these very remote areas, is because the Ministry of Health had their search campaigns around the peripheral health unit. So we talked to them first, and that's also why the three of us jointly are in this stage, right? So we were coordinating with the ministry to locate our study and try things out in the places where they did not already have a plan. Okay, so now we administer vaccine and register people. So the idea is you mobilized earlier, hopefully lots of people show up within that 48-hour period and get vaccinated, and that's going to allow us to be more efficient and cost effective. Okay? And then, as I said, there were these two different like sub-treatments that we tried. So one was door-to-door mobilization. This is what it looks like. Often it's not a physical door you're knocking on, but you're going and talking to people who are at home. Right? That's in one set of treatment, half the set of villages. But the other concern here that I have to point out is that some doors can be very far. Right. So even when you go out to the community and you're setting up in the center of the village, right? And we were randomly choosing some doors to knock on for the purpose of research, right? Like it took us, one of the adjustments we made is that, sometimes we just have to give up on the extremely remote doors because it just takes too long to even get up there. And then the other thing that we did was go to places where there were groups of people, right? That's going to be the other treatment. So in this case, there was a group of men who were working on the farm on a project together, like digging some kind of ditch. So that's going to be our other strategy. So that's what our intervention looks like. So now I can just tell you quickly what the results are and how they compare to our existing knowledge on vaccines. Okay? So we do all of this. Let me skip over this. This is just like the flow chart we use to train people on what we're doing. And this is what the results look like. So in the control group, about in these remote communities, about 7% of people were vaccinated. Okay. And after 48 hours, we were able to get the vaccination rate up to, with the door-to-door mobilization, to about 35% or 32% with the group mobilization. Okay. And so these are, statistically very different from the 7%. Okay. And another way to say it is like regression adjusted, the effect sizes, our treatment effect sizes, is getting 27 percentage point increases in vaccination, right? Over through this 48 hours of activity that I just described. Okay. Okay, so how should we think about that? Is 27% a large number or not, right? So here I'm comparing our study effects to, we've quickly done, by the way, all of this is like happening in real time. We had to finish the study just before Ramadan started, just because people wouldn't take a vaccine after, while they're fasting, right? And so we just got the data, and our entire team, many of whom are in the room, they've been working day and night trying to process the data to put this up, including like finding data from other studies, right? So there's a lot of activities, in a lot of like vaccine research that are based in the United States. Most of these studies are, that are about like using a variety of behavioral science and nudges and text message reminders or phone call reminders, etc. Right? And so our effect sizes look much bigger than those, right? In terms of percentage point increases, the 27 is much bigger than those. And it's comparable to the closest comparable study is by Abhijit Banerjee, Rachel Glenister, and Esther Duflo, where in Rajasthan, they went out to villages and set up a clinic. So they also did really hands-on intensive activities in order to get childhood vaccination rate, childhood immunization rates up. And so that's right on top, the Banerjee et al. Study. And that's where they find a comparable effect size, right? So that's in terms of percentage point effects. And then, Uddin et al., that's a study in one particular slum in one sub-district in Bangladesh where they find a similar percentage point increase. Now, when you look at percent increases, so we are basically quadrupling vaccination rates. That's about what happened in the Banerjee et al. Study in Rajasthan as well. And those are the only two studies that get effect sizes this large, right? Now, the second question we have to talk about is that, okay, of course, we're getting much bigger effect sizes, and we do care about this, right? But we also care about cost effectiveness, right? So when you get these small effects in all these other studies, right, it's also not very costly, right, to send somebody text message reminders, etc. Right? So how much does it cost us to get this increase in vaccination? So I just computed these numbers. We have really good numbers on cost because we had a subcontractor who gave us a budget as to how much they need in order to get the implementation activities done. And so per vaccine administered, our cost is about $30. And I would say this is probably the most hard to reach, most remote rural place where you can get vaccinations out. And out of 30, about $8.50. So let's say a third of the cost or a quarter of the cost is sort of a fixed cost component, right? Which would sort of come down at scale. But the rest of it is variable cost, which is like the fuel, the vehicles, et cetera, et cetera. Okay? So it's about $30 per vaccine administered. Now, if you compare it to many of the other studies, right? So let's go, I mean, Banerjee, Duflo, Glenister was the closest related study, the India work. So that was actually a lot more expensive, it turns out, right? So for them, it cost $28 back in 2010, which in today's dollars would be about 37.
Up next, I'd like to invite someone who has become a bit of a household name during the pandemic. When misinformation was in the air, Dr. Tasnim Jara took to social media debunking said misinformation and tackling the problem at its very source. She's now the co-founder of Shohoy, a health tech startup working to make reliable healthcare information available for all in Bangla. In less than 2 years, her health videos have clocked around 500 million views and have gained 7 million plus followers on social media. She was recognized as a vaccine luminary by the UK government, and I'm glad to invite her to a talk on tackling misinformation.
Thank you very much for the generous introduction. If we can move to the next slide, which shows the QR code. Oh, sorry, that's not the slide, but you probably have the QR code to pose questions on your table, so feel free to ask questions as we go along, and I'll try to answer as many as I can afterwards. So I am a clinician by profession. My day job is to see people who've become unwell and treat them. As the COVID-19 pandemic was unfolding, I was working in the emergency department of a public hospital in England. As some of you may remember, most of the COVID patients were being treated at home. Only the patients who became really unwell, came to the hospital, and at hospital, their first point of contact was us, the emergency doctors. So I was regularly seeing patients who became really unwell with COVID, and ambulance after ambulance, it was the same story: COVID, oxygen levels tanked, and we were starting them on life-saving treatment in the emergency department. As part of my work, I witnessed firsthand how devastating COVID can be to a person and to a family. So that was the picture at my hospital. But when I would come home from work and I scrolled through social media, I saw lots of posts going viral claiming COVID's not real, COVID's only a minor illness. Some promoted harmful practices as the definitive cure for COVID, while some experts claim that COVID's not going to come to Bangladesh because it has a warmer climate. Now, this contrast between what I was seeing at the hospital, what I know from my training in evidence-based medicine, and what I was seeing on social media really troubled me. Because in a health crisis, the first thing people need is reliable health information. If people do not know what COVID is, how serious it can get, how it spreads, it's unlikely that they would be able to stay safe from COVID, and fake remedies can foster a false sense of security, and by the time they seek help, it may be too late. So it was from this place that I started thinking of making short explainer videos on COVID. I was fortunate to have received training on evidence-based medicine from University of Oxford, which basically enabled me to fact-check those claims quickly, even if they were coming from other doctors or experts. So I started making videos and posted them on social media. All of them were in Bangla. My Facebook profile at that time had a following of about 30,000, and I thought some of those people will probably watch the videos and it may be of help to them. And for the first couple of videos, 10 to 20,000 people watched them, left great heartwarming comments, and I thought it's going well. While I was doing this, I found that a lot of people were confused about when to go to the hospital. So I heard that even people with mild COVID symptoms who did not need to be at the hospital were queuing up for hospital beds. And from experience, I know that if this were to happen, then the hospital system can quickly get overwhelmed. So I made a video explaining when people need to go to the hospital and when they can safely treat the symptoms at home. So I made the video, posted it, went to sleep, woke up, and saw that more than 100,000 people watched the video. I felt great. There were a lot of heartwarming comments and feedback and questions. I went to work, came back, checked the stats, and at that point, I could not believe my eyes. More than 1 million people had watched that video, that homemade video in that time, and over 500 people were watching the video at that time. You probably know that feature on Facebook where you can see how many people are watching the video live. And there were many, many questions from people about different topics related to COVID. And this changed a narrative in my mind that it's not only misinformation that can travel far, accurate health information with just boring science also has a chance. So we kept making these videos through the pandemic, answering people's questions, answering people's concerns, and providing information that became relevant with time. So as we were doing this, the challenge we faced was how to reach this to people who are not on the internet, who do not have access to the internet, who do not have access to their smartphone devices. And the videos were being watched by millions, which is good, but then that's only a small fraction of the entire population, and we thought this information is important and should reach as many people as possible. The theme of collaboration keeps coming back to this conference, doesn't it? So we collaborated with partners who were as passionate as us in reaching accurate health information. We collaborated with BRAC and 10-Minute School, which is an online learning platform. BRAC used the videos and trained health volunteers on the ground. We partnered with Grameenphone, which is the largest telecom operator. They had a very strong presence on social media, 15 million followers strong. They had an app called My GP app. They used these platforms to distribute the videos. We worked with A2Y from Bangladesh government, Sajida Foundation, Bangladesh Red Crescent Society, and these valuable partnerships helped us reach these videos to people who we probably would not have been able to reach otherwise. So as we were making these partnerships, we were wondering what else we could do to collaborate at scale. So we looked at our colleagues from different fields and were inspired by people in the field of technology who make their codes open source, which makes it really easy to collaborate. We were wondering if we could do something similar for our project. So we made our videos copyright free and called on our network to use these videos on their own platforms, on their own handles, on their television screens, or however they can to spread the word to the community. And then these videos were picked up by news channels, by different community groups, organizations from different parts of the country. So these were pictures sent to me from people from different areas of the country. So one of the pictures is the video being played on a billboard in Bariyarhat in Chattogram, and the other is the video being played on the screen of an Upojela Porishad complex, which is a local government office in another part of the country in Rajbari. And we've had similar photos come from Potuakhali, Gaibandha, and other parts of the country, from tea-side stalls as well. I'll share a quick story here. Someone sent me a message saying he went to his village local stall. Some of you know it's called Tong. And he saw that the shopkeeper was playing these videos on his screen for anyone who's coming in to buy things from him. And I thought this was really inspiring because it showed the power of community and collaboration. So as we were doing all this, the vaccines arrived. And we saw that the vaccines posed a different kind of challenge, a different kind of misinformation and disinformation were coming through. As the vaccines were being deployed, a lot of people were hesitant to take the vaccine, so much so that the deployment plan had to be revised because not enough people were responding that they were interested in taking the vaccine. A study done showed that almost 40% of people were not willing to take the vaccine, and even of those willing, only 35% of people were willing to take it as soon as possible. The others would defer the decision, sorry. And we know vaccines can be life-saving. So if people defer the decision to take vaccines, this can cost lives. So we took a different approach to what we were already doing. We kept making the videos, we kept addressing people's concerns, but I also reached out to religious leaders so that they can mobilize their community and give information about the benefits and risks of the vaccines. I interviewed experts from universities, people who are working on the vaccine, scientists on the teams who developed the vaccines. I wrote op-eds on newspapers to encourage responsible journalism on side effects of vaccine, and also unashamedly bothered my contacts at news channels so that they correct the misleading headlines on vaccine side effects. I also answered questions on television channels, on newspapers, and on my own platforms that people had as they were being offered vaccines. So this was, in short, how we tried to tackle COVID-19 misinformation from our platform. Now, what was the impact? It's difficult to quantify the exact scale of impact, but we've had many, many messages and stories coming from people saying it helped them make decisions about whether to take the vaccine or not. It helped them take care of their loved ones who were suffering from COVID, and it helped them stay safe from COVID. What we can quantify is how long these videos were watched for. And so this morning, my team tallied the numbers of how long these videos were watched for, and it was quite striking. So in total, our videos were watched for over 1 billion minutes. It was news to me as well. Thank you. And I could not wrap around my head what this means. So what does 1 billion minute mean? So I took the calculator and tried to break it down into weeks and months, but even then the numbers were too big. So I calculated them in years, and it comes up to 2021 years of watch time. So that is the power of new media, collaboration, and community, and this is still sinking in. In total, we have 8 million followers across different platforms. Our work was our work was recognized in the G7 Vaccine Confidence Summit by the UK government. We were also featured by BBC World Service in their program called People Fixing the World, where I shared the lessons we learned on tackling misinformation during COVID. And they were also featured in different news channels, including the Daily Star, ITV, Sky News, etc. So now what's next? As we worked on misinformation during COVID, we realized that this problem of health misinformation is not exclusive to COVID, but rather spans across almost all health conditions and illnesses. So to address this, we started an organization called Shohai.health, where we try to provide accurate, clear, reliable information to people who can access online. So this is all written in Bangla. What are we trying to accomplish with this? We are trying, so if you imagine when someone searches for a health problem online in English, they will come across websites, reliable websites like NHS, CDC, and they know they're getting reliable health information. But we were trying to find such a reliable site in Bangla language, and we couldn't come up with any. So we are trying to build that from Shohai. We have a team of very hardworking doctors who are trained in evidence and who are excellent in patient communication. We are trying to make a platform where accurate health information will be available in Bangla for all kinds of health conditions and illnesses. We prioritize areas where misinformation is rampant, such as sexual health, and areas where accurate information can be life-saving, such as maternal health. We have just started this work, but our website is now visited by over 300,000 people every month, and it's growing every day. We are now looking for partners who can help us reach this work to people on the ground who do not have access to internet, who do not have access to devices, and can really make a difference in those people's lives. We are in conversation with a few partners to see if we can also use these videos to train community healthcare workers, because as we have heard over and over again through this conference, community health workers play a key role in healthcare and sometimes are the only point of contact of healthcare for a lot of people. And videos, I believe, have the power to foster learning in a very different way, where clear instructional step-by-step videos in settings that they're familiar with can empower community health workers, and they can easily understand and remember what to do to save lives when they're faced with an emergency healthcare problem. So if you feel that we can partner with you or we can be of help to you, please reach out to me. And hopefully this was helpful for anyone who's looking to help tackle misinformation. Thank you. Open for questions. Okay, there are a few questions. I'll just try to read them quickly. For uploading videos. Okay. So most of them are from anonymous anonymous delegate. So someone asked, the virus was new even for a medical practitioner like you. What was your process for ensuring credibility before uploading the videos? So like I mentioned, I was fortunate to have training in evidence-based medicine, so I had the capacity to assess health claims. And how I try to ensure reliability is I try to give sources to whatever claims I was making in the video, so anyone could then click on the link and go to the original source and try and find out why I am saying based on what I'm saying. So I think that helped create credibility, and we also were very particular in making sure that we do not include any information that is not of the highest quality of evidence, that is not up to date. In a still alive ocean of misinformation, how do you think Bangladesh can do something sustainable from a government level in case of another similar crisis? Well, that's a very difficult question. I think we probably cannot eliminate misinformation. It will probably always be alive and thriving. It has been there for a long time, and social media and internet has just made it a lot more visible and a lot more accessible to more people. But I think what we can do is also make sure that reliable health information is available side by side on those same platforms, so that people can have a choice what to follow, can have time to think, pause, reflect, and make informed decision. So Asif has asked a question, can this model be applied for other misinformation in social media, or do you want to stick to health? I think for us, we will stick to health, but we also see how this model can probably be potentially translated to other sectors where experts can come in and break down complex topics in a way that people can easily understand, and that can help debunk a lot of myths and address a lot of misinformation in other fields as well. Monju Rashid has asked, how much positive impact do you think your tips have had on social media regarding COVID-19? How did you get inspired to do this? Were there any challenges? Well, like I said, it's difficult to quantify how much positive impact, but we've had a lot of messages, a lot of emails, a lot of stories from many different people saying that the videos helped. And how I got inspired is basically from my experience of working with COVID patients and also knowing how the health system in Bangladesh works, having worked in Bangladeshi health system as well. So I think knowing the impact, the disabling impact of misinformation kind of helped me move forward with this work. Were there any challenges? Yes, there were many challenges. I think one thing that I could mention is probably when I was doing advocacy on vaccines, and at that time the climate was not very friendly and there were lots of conspiracy theories going around, and some people were really angry that I was advocating for vaccines, and I was called names, sometimes called murderers, and a lot of vile things for advocating vaccines which they thought would kill people. But I tried to explain to the best of my ability that best quality evidence shows vaccines save lives rather than the opposite. I think that's all the questions. Thank you very much.